Hi, I'm Dr. Shay John. I'm a GP in Barking and Dagenham, clinical director for the CCG in Barking and Dagenham, and lead for the Prime Minister's Challenge Fund for BHR economies. Our health economy is in dire straits within the hospital: overperformance, poor quality, poor patient experience. There has been some improvements, but nothing near to the level that we need to be at in terms of the rest of the country. The only thing I would also say is that because of this, there's been and the NHS, the TDA, all these big agencies have been involved. They really are pushing this collaborative work so far. But in terms of our community, with our local authority, we have integrated care teams like many of the other sites. We, for the last 3 years, 2.5 years now, where we have, community GPs, district nurses, practice nurses, matrons, social workers, and mental health practitioners within clusters within GP practices, which has been collaboratively done. Further to that, in terms of setting up, because our one hospital supports three CCGs, the Barking, Havering, and Redbridge CCG, we have had to do a lot of, with the local authorities, a lot of joint systems. So we have a joint assessment and discharge system within the hospitals, which all three local authorities have invested in and supported, as well as having CCG support. Further to that, we've also, in terms of co-commissioning, we using our Section 75 agreements, as well as looking at piece of work for our frequent flyers or frequent attenders, we co-commissioned social workers with mental health skills, because we found there was a lot of patients who were re-attending hospitals with mental health issues, who could do with different roles within the local authority to help support these kind of patients. Further to that, in terms of integrated commissioning, we've mapped out through the Better Care Fund between the local authorities and the CCG exactly on the. We've looked at key objectives and key things that we'd like to do together. We've both collaboratively looked at outcomes that we'd like to do. So, for example, with local authority, reducing the number of residential care, real things that local authority have to deal with, and we look at other aspects for us, like reducing the admissions and looking at improvements in the quality of care with our primary care teams and so on. So we've done this mapping exercise. We've got shared outcomes. We've looked at, through the Better Care Fund piece of work, we've looked at where there was things that we could improve on. So there were things that we weren't very happy with in terms of carers and the voluntary sector. So collaboratively, we've had to put that in through this mapping exercise to support shared objectives for improvements in end-of-life care and obviously supporting carers. Further to that, we were successful in getting the Prime Minister's Challenge Fund, which was a £5.6 million investment. And using that, we've used that some about GP access, improving GP access within the community, but also further to that, the more exciting thing for me is having a complete complex care team based on the highest number of long-term conditions. And this was based on the year of care work that some of our partners have been involved with. And what we've looked at is actually commissioning a team that has the full team from day one, so a GP, consultant, district nurse, matron, social worker, and that's done collaboratively with that. We have to roll out within the next 4 weeks. We've been given it, it's got huge deadlines that we have to do, and by the end of the year, we will have had 1,000 patients commissioned by this complex care team, which is a completely separate new entity which has been commissioned completely through this money, as well as the local authority and CCGs. And by doing that, and obviously priming all of this, we hope to obviously take money out of the acute trust to fund it further in the long term. Further to that, we've also looked at co-commissioning in terms of things like education. So we have a huge end-of-life project we've used one of the hospices to do training of end-of-life care, and we've been careful to not only train, for example, our GPs and our practice teams, but also the social workers, carers, as part of all of this, using this money to do a kind of more system approach, so having a real innovation that way. And further to that is we were always waiting for the shared care record kind of thing. We never really got there. So out of the 5.6, a large chunk of it is actually to create a IT infrastructure through the whole system, so that any practice can access any patient's notes, and equally they can be shared with our social worker team, so a local authority team, as well as our community teams and our local local trust. And the benefit of that is that wherever you put the system, they'll have the most amount of information. Wherever the patient gets seen, everyone will have the information to hand, and that was for me, that's a real win, and that's being rolled out we hope, by the 1st of July, the first week of July, that infrastructure will be in place. In terms of, so based on that, we will have this we'll have this specific team that is basically a whole team, holistic team for the very kind of needy or the most complex patients. And then further to that, and we will build on that, based on that, our other teams that work in the community as such. And our BCF, as well as our quick plans, are all based, they're kind of support the co-commissioning and the future commissioning of integrated care. And that's how we've mapped it out. Now, as for the primary care question, what we've done is there's been a new lot of contractual changes within primary care. You know, for example, having a named GP lead for the over 75s, looking at reducing admissions, which is part of the contract. And what we've done is we've done a mapping exercise of the levers that are out there and that we can use to convince the primary care teams to come on board, which they are, and also to understand the levers across the whole system to bring the systems together, wherever it is. So it may be from the contracts, the GMS and PMS contracts levers, and the DESIs and LESIs, as well as looking at what other levers there are through public health, through the local authority, and so on. So we have almost like a collaborative commissioning in terms of incentives. And in terms of stakeholder engagements, we've got quite a large, complex plan in terms of to roll out side by side with the developments of the new system. So in terms of patient engagement, having all the different stakeholders, so they're completely aware. And I think in terms of the GP community, all three boroughs now are trying to get into a federation agreement. And the reason we prefer that is because it's very much easier for a local authority to do business with a federation, i.e. all GPs in one go, than it is to do it individually with, in Barking and Dagenham, there's 42 practices and having contracts for each one, and trying to manage it. The federations are in place, and the federations are also part of the governance structure for the Prime Minister's Challenge Fund, the three federations across the three different CCGs.
Okay, Jay, let me come in there. There's an awful lot in there. I want to go to Sue and then Nick first for some questions. I'm sure you want to dig into some of the details, Sue.
Well, it sounds sort of great. I'd be interested to know a little bit more about the care plan that you put in, because we're just about to hopefully launch something as well called Share My Care. So does yours actually link with the acute trust and the ambulance service and everything as well? Or?
Yes, so we've got a virtual care plan which is accessible to carers as well as patients or the people that can use the IT. If not, it's a handheld record. But yes, the accident emergency, they can access the care plans. And what our integrated care teams do, they have to update the care plans. And how we got that updated, we made it as a KPI for our main community provider, that they have to load this on a regular basis onto their care plans. So any professional that's involved with that will link into the care plan. It's a virtual care plan that uses a system called Health Analytics, which is our kind of tool for risk profiling, as well as it takes information from primary care, social care, as well as and we've joined up with the LAS as well as the local trust who can access it. And that's why it was really important, because our teams now are actually in the community, so the social workers and our community teams and GPs are sitting in GP practices. Well, they needed something that has a common linkage. So, I think further to this, having this additional primary care ability to look into different patients' notes and so on, well, to a degree, we further expanded on the actual care plans itself.
Okay, thank you.
Nick, questions for Jay?
Yeah, I think I don't think you necessarily covered it, but I'm just interested in your view. As I understand it, your area, BHR, is quite a complex and diverse, both ethnically and from a sort of a demographical point of view. It's quite a diverse. You've got a lot of diversity, which in turn brings very, very different and diverse requirements from a social care and a health needs perspective. How are you predicting the demand for those services and the type of services? How are you doing that work to make sure that the service that you're planning for at the moment is fit for purpose in 5 years' time and meets the needs, but not only that, is future proofed? And I'm asking the question because we're going through the same challenge, but I wouldn't have thought we have anywhere near as the sort of amount of challenges as you have, or complexity as you have in your area. So I'm just interested in how you're doing that, and probably generally from everyone else.
So that's a good question. That's a very big point, and it's an issue that we've been continually dialogue. So our approach is we've used a lot of public health data and Public Health England data in terms of and of course census data to look at some of the ethnicities, and where the ethnicities have also generated, they generated particular disease groups. So, for example, in my area, sickle cell anemia is a very common problem, and we have to, as a CCG, we've had to commission a sickle cell service because of that particular issue. And in terms of developing the teams, we've had the very important thing is to also have some of the stakeholder engagement. So there are cell groups, there are different ethnicities. So there's a Eastern European group. There's we've engaged with a lot of those groups to help with some of the design aspects in terms of developing what the on the ground teams feel like. Now, in terms of our 5-10 year plan, well, although our commissioning cycles look at more year, we do have a 5-year and almost a 10-year plan of because we need to know how many numbers are coming in, what kind of admissions, because one of the biggest issues with outer London boroughs is that we do have this real natural population coming in and out, which provides difficulties, especially if you're building the data about these patients and they disappear and someone else comes along. It's a very complex. But that's why, in some respects, having 3 CCGs working on together, the movement between the 3 CCGs doesn't become a problem. Our integrated care teams now, before it was traditionally Barking, Dagenham, Havering and Redbridge. Now there's a lot of cross cover because we're practices that were on the borders of 2 particular boroughs. We've had to bridge some of those issues as part of this project as well. But it is a continual feed. The health and well-being of the board is actually the kind of the kind of senior governor in terms of helping shaping any issues that come up. But we do have a very clear understanding of where we are now and where we have potential in the future, because that is, like you said, future-proofing what we do. That's where we are. So it's engaged.
So is it integrated with the social care side of things? Because is it kind of, are you from a capacity review perspective? Are you looking at what the demands of the local population will be and the different groups from both and looking at how that commission activity will work from an integrated perspective, or is it done in isolation?
No, it's actually a joint project. So, for example, some of the carers, like for example, if you've got look at some of the Asian groups of people, there tends to be a lot of families and carers that are very much involved with those particular. They tend to be in-house, and it's how those kind of groups. Whereas you've got a completely different spectrum where you have literally almost completely dependent on the system as well. It's trying to manage both. So that's where the whole stakeholder engagement becomes. We've used a lot of Health Watch to kind of bring those kind of different views in, from the disabilities to different ethnicities and so on. And they've been very useful, in my opinion, in terms, because they do a lot of surveys, and they tend to bring in a lot of criticism of some of our plans, which helps to define some of our issues that we had. We hadn't within our particular area, we were closing a walk-in centre, and that caused loads of issues. And it was Health Watch was quite instrumental about telling, we need you to do something different, and the CCG changed as a result, based on the evidence. But I think it's a very good point. I can't say we're 100% future-proof, but as much as we can, we've tried to do.
Okay. Jay, it's Matthew here. We've had a tweet from Simon, who says that he's concerned that often the voluntary sector is assumed to be the patient's voice, but often it can mask or hide individual patient voices. Can you just say a little bit about how you have engaged the voluntary sector and how you've used Health Watch so that you actually get to hear individual stories and individual points of view?
Yeah, so Health Watch have been quite good in developing more. It's not biased. It tends to be patient voices of the people that are very much interested. The voluntary sector, you're right. In some respects, it can be sometimes quite skewed, depending on some of the the groups and so on. But I think we tried to have a consensus group. So we had a stakeholder group. As well, through our own economies. We also have Health Watch, who have quite a various, because some of them were previously links and other agencies before that, so they've got quite a good kind of directory of some of the groups that they have. And we also have our own kind of, in part of the design workshops, we invite patients directly to the design, so they're literally feeding in the kind of issues that we have within our communities. The other thing that I've got to say, the local authority have actually got a really good catalogue of all the different groups out there, and they've been really helpful in getting some of these groups. I know in Barking and Dagenham, the local authority, they've had some really good ability as a commissioner to give us an idea of what kind of people, who should we be engaging, and what groups are out there, because I don't think we all, as GPs, I'm 100% sure I didn't know how many groups there were out there, and I think sometimes you have to use other organisations to help channel in some of the different voices, as well as actually having events and inviting people. Health Watch had done newspaper adverts to bring people to come to these events. They've sent out emails, they've sent out on various ways on radio to encourage people to come to their events to talk about some of the issues that people were having and facing. So I thought it was a very good, our first Health Watch event had almost 120 people turn up, voicing some of the issues they have with local services, and also, really do know what they would like in the future, what they see as a good service, and that's quite sometimes it's a quite a difficult challenge